Hey Mo,
Hey Ricky,
the doctor is in.
we are, and we're in with such an in and timely topic, right? When you
Yeah,
think about what's moving the needle forward for cancer treatment and what's really changed in the last probably 5 to 10 years, even genetic testing.
yeah,
Genetics is one of the key drivers, I think, of helping us to personalize medicine. But not everybody's getting offered all of what there is, and not everybody even knows or understands that, because sometimes I ask a patient, do you what have you had genetic testing? If they come see me for a second opinion, did your doctor offer you genetic testing? They'll say, yeah, I'm ER positive. And there's a lot of misinformation, I think. So we're going to like demystify what genetic testing is. We're talking about genetics versus genomics, why it's important. So many good things today.
yeah. And just even knowing your her story. So I had genetic testing. I don't have any mutations, but I have a family history. So what is that? How does that play into this? And for so many Black women to get triple negative breast cancer and not have a genetic mutation, something is wrong with that picture. We lost two breasties this weekend. It was a rough week. And TNBC, one was 39, one was 43. And we got to fix the madness. We got to fix it. So we have two awesome guests. Our breastie Laura, my breastie Laura, who is our buddy, partner in crime, from Touch for Life. And then her good friend, Maya Roberson, who we just met at SABCS. Laura brought us together with her. And I
Hmm.
forgot about that. Like, so crazy. Like,
Yeah, Dr. Maya's awesome. She had a poster there, right? And you can tell us about some
yeah,
research that
yeah,
she's doing.
yes.
And then Laura, tell us about your background too in healthcare and kind of how this became of interest to you.
Oh, sure. Thank you so much, Dr. Mo, my bestie Ricky. Thank you for having me. So I founded Touch for Life, which is a 501c3 nonprofit focused on breast health equity, and in particular, genomic or biomarkers and genetic testing because the rates are so low. I came to this conclusion after seeing so many academic research papers and the data about how we are not represented, one, in what I call the bio data.
Yeah.
So when you think about tissue and discovering mutations, we're less than 3% of the bio data to start with. When you think about looking for mutations and looking for therapies, that's kind of the beginning.
Yeah.
It's 79% European based. So when things are being discovered, mutations, we're not represented. And that was a shame and criminal. And then when I think about as precision oncology is the gateway to clinical trials is more and more around what mutations you have and biomarkers,
Right.
and you'll just be left out of it. And I thought in talking with my advisors that this is the place to focus, because we've got to be upstream, included in the data set. The mutations have to be found, and so that the drug therapies can be discovered to target what's driving our cancer, because
Right.
Black breast cancer is different, as my friend Ricky always says. So I've lost friends and I'm sick of it. I'm really sick of it, and we have to do something different.
We're sick and tired of being sick and tired of people dying. Right. Right. So
Wow.
how'd you meet Dr. Maya?
I had the great pleasure of being a speaker at doing an interview at the National Society of Genetic Counselors, which is an annual gathering of genetic counselors and genetics and genomics testing companies. I'd love for Dr. Mo to explain the difference for the audience. And it features companies in their latest research discoveries, mutations, and there was a standing room only session that I literally was sitting on the floor because there was nowhere to stand or
Wow.
and it was Dr. Maya had a presentation of a poster and her research that she'd done as part of being an epidemiologist in Vanderbilt. talking about the inequities of testing, specifically around us, and why we're not offered the testing at all, and what's going to happen to us when we're not tested. And so, to me, that means that the drugs that are prescribed in our care pathway, they're hitting us with a sledgehammer when really all they need is a precise tool. And so Dr. Maya, I went up to her right away and said, gosh, I've got to know more about your research and the great things that you've done. And we quickly formed a friendship and a kinship. And that's why I wanted to bring her to the attention of the Touch Black Breast Cancer Alliance audience, because I think she has important information to share. And I also want to say that I was on the phone with a friend. She was getting her diagnosis, and I was on the phone with the doctor. And I asked the doctor, tell me what subtype she has. And it was crickets. And I thought, how are you going to treat her? And so
all the time. It's so
yeah. So then we have to do something, and that's why we sprung into action, not just to be angry, but to take that anger and do something about it. And that's what we're trying to do.
Right.
Wow. Dr. Maya,
She's here to
welcome.
save the day.
Truly. Tell us how you got into this research. Tell us your why. And then we'll go from there. But we always like to just kind of know, how did you get to this awesome place in life?
Yeah, I think my why started in a very similar place that many folks, specifically many Black women, let me be specific in this space. So I remember being actually an undergraduate at Brown University taking a public health class, and my professor at the time put up that classical graph that we all know very well of the time trends and mortality in breast cancer stratified by race, where we see that breast cancer, y'all all know what figure I'm talking about, where we see that breast cancer mortality has been declining over time for everyone, but much, much more sharply for white women. And in fact, the mortality gaps have actually widened over time. So as we've gotten better at treating cancer, these mortality gaps have widened, and we hear these really heartbreaking stories like each of you have shared so far. And so it was seeing that figure in this class and feeling very deeply in my core that is just so fundamentally unacceptable, that I felt very deeply. And what continues to motivate me is that if we are going to continue to get better at treating breast cancer, everybody needs to benefit from those advances, and we are constantly playing catch up. And so that's where this had started for me, literally being 18 years old, sitting in a public health classroom and seeing that figure and saying, you know what, at that time, I wasn't quite sure how I wanted to dedicate my career toward it. But I wanted to figure out a way that I could. And for me, I've always been kind of naturally quantitatively inclined. And so that's where approaching this question and this fundamental issue from an epidemiology, health services research sort of lens came into play. And so I'm a health services researcher and assistant professor at Vanderbilt University School of Medicine in the Department of Health Policy. And really the core of my research program is studying these sorts of population level factors, particularly among Black women, about who is getting the latest treatments, who is not, and how do we fundamentally close these gaps so that we're not constantly playing catch up. And so currently, I'm funded by the American Association for Cancer Research in partnership with Victoria's Secret and Pelotonia to look at this question that we're all talking about here today, specifically around genetic testing, genomic testing in Black women, and how do we better understand the structural factors that will enable more Black women to get the testing that they are recommended for.
Wow. So you know what? Let's go back a little bit because we get calls every day from new people who are just, newly diagnosed, right? And they don't even know what genetic testing is. They never heard about it. And guess what? A lot of them don't even know their HERstory. that their grandma Edith had breast cancer, or their aunt whatever on their dad's side had breast cancer, because they're not talking about it. And so we're really at a loss from the beginning, because we don't even know we don't know, right? So once you introduce this topic, like, I think our biggest challenge is, like as Laura said, they call and we say, what's your subtype, and what, did you have genetic testing? And the answer is always no. It's rare that they say, yes, I had genetic testing. And then even the ones who've had it don't really know what it means, don't really have a clue how it could impact their treatment. Nothing's explained to them. So I don't even know where to start with this conversation with how to help people. You guys help me. I mean, I'm not sure, because I feel like first we got to just get them to understand to ask for it, and like stand up and, as soon as you get diagnosed, that's one of the questions on the list that we give people, like of what to ask.
And I think you're right. And I think we got to go back to, even before we could talk about testing genes, even defining what a gene is.
What it means. Yeah. Can you?
Right? So let's just start there. Dr. Maya, if you want to tell us what a gene is, and then we can get into why it's tested and what happens in the body and the difference between genetic and genomic.
Sure. So I guess I'd like to start with that second piece first. I think working backwards kind of helps articulate what we're talking about. And so there are different types of genetic testing that folks can undergo. I think many of us may be aware from the popular media of the BRCA genes, BRCA1 and 2, that gained a lot of popular press attention, particularly after Angelina Jolie over a decade ago had mentioned that she was a carrier for this mutation and had decided to undergo a prophylactic, the removal of her breasts and ovaries before she had gotten breast cancer. And so these particular genes increase an individual's risk, lifetime risk for breast cancer to be astronomically high. But the BRCA genes aren't the only types of mutations that individuals can have. Now, in the contemporary era, clinicians will run panels of genes to detect for mutations. And not only in the case of BRCA, do these mutations increase one's lifetime risk of breast cancer, but now back to that point I was making earlier about how we've gotten so much better at treating breast cancer. Now there are targeted therapies for individuals who may have metastatic breast cancer who have BRCA mutations. And so even on the back end, if somebody already has breast cancer, it's important to know their mutation status to be able to help identify what treatments may be appropriate for them. And so these sorts of genes that I'm talking about here are called germline genes. And so they are tested for using the blood or the saliva. They're inherited. They can potentially be passed down in families. That can be contrasted with somatic testing, tumor testing, when individuals with breast cancer have their tumors tested to look for specific alterations within the breast cancer itself to, again, potentially identify targeted therapies. And so when we're talking about genetic genomic testing, it's, as was being alluded to, not uncommon to not know what you've had. And so many now pretty almost universally individuals undergo ER/PR testing, estrogen receptor, progesterone receptor testing, as well as HER2 testing to determine their breast cancer subtype. But that's not the same as genetic and genomic testing in the same way. Because there are so many different moving parts and what is going on, it's truly hard to know what you may or may not have had unless you use this very specific, honestly technical language to try to figure out what you may or may not have been tested for. And so working backwards, that's kind of how I think about genetics and genomics and how they may shape how folks may be at risk for breast cancer to start with, or once they already have breast cancer, how they may or may not be treated.
Sure. I think that's a really important framework. I tell patients that the genes are like the blueprint, right? And everybody has a blueprint for how they're going to develop. And so the genetics looks at that blueprint, that hereditary blueprint. So, there's other hereditary things like Tay-Sachs and Huntington's disease. And when you have babies, when you get pregnant, they test for a whole panel of things that you could pass on to that unborn child, right? So all of those things are the blueprint that you got 50-50 from mom and dad, or that you inherited from mom only or from dad only, depending on what genes and chromosomes we're talking about. But then the genomics is the whole environment of the person, right? Like the interaction of those genes in that tumor, in those normal cells, in that entire body, the environmental component to it also. So the genomics is a little bit of more of a snapshot of what's happening now, not what you were born with. That's the germline that Dr. Maya was talking about, the seed. You think about germinating seeds, right? When you're growing stuff, for the gardeners watching, that germination is what's passed down to you, but then the environment in which it all grows and the plant that comes up from it that's the somatic, or the person that we're testing. And you got to test the tumor to look for those hormone receptors, the estrogen, the progesterone, the HER2, what's driving the cancer to grow. But now we can go even deeper, and we can look at the tumor genes that are turned on or turned off, like radial dials, when you look at the switchboard, right? What genes are turned on and off in us, in that tumor, that might make cancer happen earlier, happen again later, early recurrence, late recurrence, right? Distant recurrence, local recurrence. There's all these different signals that a tumor can send out to the body. And so we have to test for those things so that we can know what
We know,
signals or
right.
what that tumor is telling your body to do. And it's a lot more intricate even than it sounds in the basic explanations that we're giving here. But it's important information because, like Dr. Maya said, when you have certain mutations, we know that certain drugs work better than others, right? Or we know that certain drug combinations might not work so well. And
Right.
so this testing is really important for the doctor to know and to do, and it should be routine, right? We have our little checklist, of what we're supposed to do, and in our tumor boards, that we check the ER, the PR, and the HER2, and our pathologists have something called CAP guidelines, the Clinical Association of Pathologists. They have to check those boxes and say they look for those things. And so we're supposed to be checking these things on everybody. And then the genetic testing, the guidelines have been shifting back and forth according
Right.
to, what insurance you had, how old you were,
Right.
what type
Right.
of cancer you had. You could look back at women in the early 2000s, Black women in 2005. They might not have got genetic testing because they didn't have the right insurance,
Right.
or their
Right.
doctor thought they didn't need it, or, whatever the reasons were. Those panels used to be
Yeah.
$4,000.
Yeah.
And now they're a lot cheaper. Now they're kind of everywhere. And now the guidelines are saying, okay, anybody who has breast cancer probably should get counseling and get tested. But what about all those people that we didn't test? And how do the doctors know? They're like, who's on first?
Right.
Who
Right.
gets testing now? And so, Dr. Maya, how do we gauge how well we're doing with all of this? Who's watching us?
Yeah, thanks for the question. It's a really good one, and one that I spend a lot of time thinking about as a population health scientist, like from a population level, how can we gauge these sorts of things? And so an aspect of my research has been looking into insurance claims data. So among those who are insured, which as a caveat, obviously isn't everybody, but it's a large
Right.
swath
Right. Right.
of the
Right.
population. We can look at large large insurers,
Right. Right.
composite insurers, to look at who is receiving genetic testing, who is not receiving genetic testing. A particular interest of mine is looking at, okay, among people who have received testing, what is their treatment trajectory? Among people who have not received testing, what is their treatment trajectory? And that's what I'm being funded to look at right now in a large database of commercially insured individuals, to kind of follow that pathway through, because what we do know right now is a pretty good idea of who is and isn't getting testing, and that is perhaps no surprise to any of us on this call.
I
But a
know it's
bit
more.
less is known about that trajectory after, about what is the actual tangible difference in care that people receive when they don't get that guideline recommended care at the decision point of testing, and to really be able to quantify that and understand what are the consequences, and so that we can really have hard data to show, like, this is what is being lost by not testing when we should.
hmm I
Wow.
can tell you from the surgical standpoint, when we used to not test women, surgeons would just do the surgery of what's in front of them. So, meaning they got a mammogram, they got an ultrasound, they got a biopsy, there's a tumor. They wouldn't do MRIs and look deeper, right? They wouldn't look at the other breast and the other side. They say, we'll just take care of what's in front of us, right? And it's the same philosophy with genetic testing, where if you test, then you must wait for those results, and then you must interpret those results with that patient, and
Something
then
of
you
that.
have to decide. Now you're at a decision tree, because if you have a mutation that puts you at 60% chance of recurrence, right? Like more than flip a coin chance this is going to happen again, you might decide a different surgery. And then
Right.
you've got to know what that surgeon's got to go find a plastic surgeon. They got to make sure that patient gets to the breast surgeon, the plastic surgeon, and da, da, da. And surgeons were not well educated, I think, in the field of hereditary cancer testing and why it was important. They said, no, all this time, all this waiting, we got to deal with this cancer in front of us. And I'm not excusing it, but what I'm saying is that it has changed the way we practice now, because
Right.
all that stuff is considered up front now.
Right.
As soon as you get diagnosed, you're getting that genetic testing. We're talking about what your surgical options are. You might have a consult with a plastic surgeon, even if you're thinking about a lumpectomy. You might want a symmetry procedure. Like, it's changing even just the way we do surgery, let alone the changes in medicines
Medicines,
that
yeah.
a person might get. And in a metastatic setting, that is huge, right? Because your drug, your whole regimen could change.
And people just don't even know to ask for this, I mean, obviously your data is showing, Maya, that we're not being asked, which is so typical of so many situations with clinical trials, everything. But so we have a lot of work to do in terms of just telling people to ask. And then once they get the answer and they do the testing, okay, now what do I do about it? Because if they're not being asked, if they're not being asked to do it, there's definitely not going to be asked to know what to do about it, right?
Right.
One of
And
the
then
things that I
we,
would like to add to that too is something that I also looked at as well, because I think sometimes we need to also understand what works well when it does end up happening. And
Mhm.
so some of the work that I have presented and am continuing to write up now is among a cohort of Black women who have been diagnosed with breast cancer under the age of 50, who have completed this series of questionnaires. Approximately half of them received genetic testing and half of them didn't. And for those who had received genetic testing, they were in this particular study, they were asked why they were motivated to get genetic testing. And the response options included things like to be able to guide my treatment choices, like chemotherapy, like surgery, like we're talking about, or to because they were motivated by their family, the potential impact on their family. And there was also a free text response that folks could enter whatever they felt compelled to about what they felt motivated by to receive genetic testing or to pursue genetic testing. And in this particular analysis, where I analyzed people's responses to why they wanted to undergo testing if they did, overall, the vast majority of these women wanted to undergo testing because of the family benefit. It wasn't actually because of the potential impact it could have on their treatment, even though that is objectively true that it could impact their treatment. That when they were asked, why did you get testing? It was to benefit my children, to benefit my sisters, to benefit others around me. And so I think that that's important to learn from, for especially for researchers, for clinicians, when these conversations do happen, that perhaps it's less about how the nitty gritty minutia of how this might shape treatment, and meeting folks where they are. The potential family motivation is what is getting people tested and putting them more at ease to know that this could benefit their children, that it could benefit their siblings. Then those are the conversations that need to be had. And so I
Right.
did want to lift that up and elevate that too, because
Mhm.
we rightly talk a lot about barriers and why folks aren't get testing. But I like to talk and look at the flip side at the same time, that for whom this has worked and who are able to successfully get tested, who are able to successfully meet these guidelines, what about those encounters enabled that? And the family motivation. And I mean, the sense of community that exists amongst Black women, and how we are very often caretakers, for better or worse, for
Right.
everybody
Right.
around
Everybody.
us. to acknowledge that how the social factors, that like very deeply social community cultural factor, plays a role in these conversations around genetics. They are not divorced or separate. They're entirely part of this conversation about how do we get more folks appropriately tested.
Well, you know, what you said in terms of the family connection, that's because that's all they know. Because they don't understand that there's implications for treatment, right? They hear genetics and that sort of reminds them of what they learned in high school. And they're thinking, okay, well, it's for my family that I'm doing this, because they're not having the conversation with their doctor about how this could impact their own treatment and how it could impact their disease development, right? So that makes sense that that they only know that part of it, so that's why it's so important to educate. And that's well and good. And, we all, we're always going to take care of somebody. That's who we are as Black women. Here we go again. Do it for my daughter, do it for my family, do it, whatever. So that's already there. But the part that could really make a difference for the patient is the important part where.
Right, because one of the big decisions you're making is,
Yeah.
lumpectomy, single mastectomy, double, bilateral mastectomy. What your treatment plan, those are some big decisions that you're making.
Yeah. And even chemo
and chemo, yeah. And the genetics can tell you your risk of recurrence. Black women are 39% more likely to have a recurrence. But wouldn't you want to know your precise risk factors
right.
that are driving that, and then what that treatment plan is to stave that off, either for as long as possible or for it to never happen, will be important for you to know.
Right.
So we also at Touch for Life, we created a kind of a what to ask your doctor document around genomic and genetic testing. Just some basic questions about, is this the right thing for me? What are your thoughts? To have a conversation with your doctor about what you are entitled to and what you deserve as a breast cancer patient, according to the guidelines. And it's really important to know that you deserve this testing, and it's right to do because it helps you and your family. I mean, look at these guys behind me, these pictures, and the testing is important for me to know. Are my sons at risk, right? Have they inherited my mutations or my risks? And should they be on the lookout early because of the diagnosis that I have? So I think it's a combination of both of what Dr. Maya said.
Yeah, and we'll put those questions out there, because we have a great group of questions, Mo, kind of crafted for what to ask your doctor on your first, couple of visits, but we'll add that to it. And
I'll jump in and piggyback off of what you said, Laura, and also note and lift up the fact that as we see women who are younger and younger with breast cancer, they may not have children yet. And so the do it for your daughter it's important for women of a certain generation. But I think helping even younger women to figure out, why did this happen to you? Because everybody has that why me, right? And being able to better understand in a situation of a family that may not talk about family history or family history that's unknown, right? And even, Laura, you brought up a really good point about, the implications for treatment, and one really good example are things like PARP inhibitors. And not to get too technical into the drugs, but basically it helps us to know when a person has a mutation, whether or not a certain category of drugs will work for them. And those drugs are a bit more tailored, they're more specific, they're more effective, which means that you could have a longer life, a higher overall survival when those drugs are put into play. And so even if you had cancer and you didn't get genetic testing at that time, or you didn't have that tumor testing, those are things that we can still go back and do on tissue that exists, right? And you got the genes you were born with, you can give us some saliva and spit in a tube. So if you didn't meet criteria in 2014, you can still do that testing today because you still have the genes that you were born with.
Right.
And so it's important for people as they're thinking about, their risk of recurrence, their future, and how to be helpful to society, to their church, to their community, to their daughters, to think about, well, you know what, I already did my surgery. Maybe I'm cancer-free for 10 years, 15 years, but I never did do that genetic testing. Maybe
right.
I should go back
I should
and
go
look
back
at
and do
that.
it. Yeah.
Yeah, because
And
there
you
is a
can.
study, actually, it was also presented at the National Society of Genetic Counselors about, excuse me, whether or not once you've had the testing, whether you get contacted, or if you haven't had the testing and you could be a candidate for another therapy or something like that, do you go back and contact the patient? And there's actually a whole body of work and a lot of deliberation that's going on within the physician community on what to do and what's the ethical thing to do, the moral thing. Do they have a legal obligation? There's a whole discussion about that. In the
Wow.
meantime, while they're figuring that out,
Wow.
once you know that you can do this, you can ask for it after, you can advocate for it and ask for the test. I asked for the test myself. And you can do it, and it can be covered. Most of the time it is covered, in fact, by your insurance. And if not, most of the testing companies have financial assistance programs, and there's another nonprofit that helps you fund it. So you can ask, you can get it done, even if you haven't had it, as Dr. Mo mentioned before.
And you can even ask your doctor, is there anything else on those guidelines that we haven't done yet?
Right.
Right? You can just say, okay, doc, seem like we covered a lot here today. Is there anything else that we needed to cover? Or what about, my family? Could this run in my family? Like, that's an easy question to ask your doctor before you leave that room or any time in your clinical encounters. Laura, to your
Right.
point, it gets tricky when we get new information and we do retrospective testing, as we call it. We go back and look at things. I remember a few years ago, we were looking at a test that would tell us if people who were on the estrogen blockers could come off after 3 or 5 years versus 7 or even 10 years. And they said, well, what do we do if we found out that, women had that their genomics said that they could come off of an estrogen blocker at 3 years and they're already on year 7? Like, what are we supposed to, how do we,
Right.
what do you do with that? And so we're always worried about how people are going to interpret the information that we give them from
Right.
the hedging our liability standpoint. But these are people's lives, right? And I think that, when we know better, we do better. And that is always, that's the nature of science, right? It's like if we knew back in 2010, then we would have done different in 2010. But the medicine has to evolve, and so the doctors, the science has to evolve. The clinicians have to evolve with the science, and there's a dragging of the feet there in general. I find that if we didn't learn it and it didn't already exist, synthesizing new information is hard. I'm wondering, what do we do about that, and how do we how do we look at and examine that as a component of the fact that people aren't all getting the same treatment? Is there a reluctance to believe guidelines or to follow new guidelines, or are the guidelines just behind in the times, or people just not doing it?
Right.
Oh goodness, that's the million.
I
Right.
know,
the
I'm
million-dollar
sorry.
question. No,
Right.
it's okay. I mean, honestly, I feel like this is where the strength and the, quite honestly, power of patient advocacy groups is so critical and has been so fundamental. I mean, I have learned so much. I'm not a medical provider, I'm a PhD, let's be clear, but I have learned so much from patient advocacy organizations like the ones the two wonderful women on this call lead. And the way that I have seen patient advocacy organizations hold people's feet to the fire on these critical issues. I mean, that is how we get change, quite honestly. I mean, I think it takes folks like all of us on this call right now, the clinician, the researcher, the patient advocates, to really come together and say that we need institutional change. I use institution broadly defined. It's this cross-sector collaboration that is what really moves the needle. Because if I'm shouting over in my research corner and Dr. Mo's shouting in her clinical corner, and Laura and Ricky are shouting in their patient advocacy corners, and we're kind of in our own silos talking about the same issues, but separately, but coming together, it's really how can we change, it's quite honestly changing norms to fight for more equitable care for Black women. And it sounds kind of trite and cheesy, but I really do believe it in my spirit that it's the bringing together of these different, quite honestly, areas of expertise. Every single person on this call has a different spot of expertise around this very important fundamental issue. And it is that pressure that I believe that we will see the needle move in all of our lifetimes to get to a point where Black women receive equitable breast cancer care.
Mm-hmm.
No,
Wow,
Dr.
you
White,
said a mouthful.
I know you said a lot, but I agree with you because, and I do believe this is me and Laura's purpose, right? All of our purposes, but I know that in my capabilities, whatever, however limited they are, I can't change a racist doctor. I can't change the white doctor who has implicit bias. But what we can change together, all of us, is how a Black woman demands care for herself. And so I think that's what we're trying to do right here, educate yourself. And I think also just to take another elephant out of the room, genetic testing is not a big deal. You guys, you spit in a cup. It's not a big deal. And you may have to like fight for it to get covered by your insurance, but if you have to do that, you have to do that. But it's not a big deal. It's a pretty easy test. And we all just have to ask for it. And it's part of, has to become part of that, one of those first conversations you have with your doctor. And we just have to keep talking about it and talking about it and talking about it until we get it, because it's critical. And we miss so much if we don't have it.
And
Yeah,
Ricky,
I'd
let
like
me,
to say,
oh, sorry, go ahead, Laura, you go
I would
first.
just like to say, having gone through the testing, it's super easy spitting it, like just,
Yeah,
it's simpler than the COVID test at
it
home,
is.
right?
It is. It is.
I will
Sure
say
is.
that the questionnaire, right, could use some improving.
Yeah.
It's quite extensive. And if you're like me, there are lots of things you don't know about your family history.
Right.
In the Black community, like, we don't talk about what Aunt JoJo died from, right? We don't know. It's kind of a secret. And then I had a friend who was filling out hers, and she kept saying she didn't have any history, but she was thinking of her dad is her stepdad that raised her, right? And it turns out her biological dad, his sisters and her biological paternal grandmother had breast cancer. It's all these complex things that we have to make sure that we're thinking through. And it's okay to say, I don't know, right?
Right.
I was born to very old parents. So like my dad was 54 when I was born. So my uncle was literally fighting in World War I, not World War II, World War I. Okay. So like, do I know what happened to him? No, I do not.
Wow.
But so it's okay to say, I don't know. You're going to talk about as many risk factors as you can.
Right.
And you just, feel comfortable with being uncomfortable, and it's okay. There's no judgment, right? It's just, you don't know. Put in what you do know. Share what you do know. That's going to be more than they had when they started.
And many of us don't know. We don't know. And I tell this story all the time. My mom had stage 0 15 years before me. And it wasn't until I got sick that she remembered that her aunt died at 42 because she was 10 years old. And my grandmother didn't talk about it. They didn't talk about it. And when she went back and thought about it, and I harassed her, she remembered that. But, we're not talking about it with our families. And so, if you got older parents like us, there's some old school stuff happening where, we all
talk about nothing.
talk about nothing. Nobody's business. You're not supposed to put your business, whatever.
Yep, that's your business. You're right. I
But-
want to touch on something Laura said, though, about knowing that family history and self-report, right? When a person gives me their family history, it truly is self-report. And so you don't have to know everything, right? We're not asking for proof of who had cancer when and who died when.
Right.
We just want to know to the best of our ability to see if you meet certain guidelines. And the reason those guidelines exist is because the majority of cancers are not necessarily going to be hereditary, meaning passed down
Right.
generation after
Right.
generation. Only 5 to 10% of all
Right.
cancers at this point are hereditary in nature. So we need to figure out, well, whose could be and whose maybe aren't. But there is a category of people who can get tested without any family history at all. What if you were adopted? Right? And you didn't know any
Right.
family
Right.
history, and
Right.
you can talk to your counselor
Right.
about that. And there's concessions that can be made, and there's conversations that need to be had in order to get insurance to cover
Right.
that testing when there's absolutely no family history. But
Right.
we're at the point now where if you had breast cancer, you pretty much meet criteria, or if your mother met criteria, then you by proxy even meet criteria. And so there's so many different ways to get tested. And what's really interesting to see and coming down the pike is not even for the folks who have cancer, but for the people who are higher risk and who are unaffected, as we call them. Because when you are diagnosed with a mutation and you don't have cancer, then the question is, how likely am I to get that cancer? Because
Right.
the
Right.
genes they're gatekeepers. And so, or spell checkers. If your spell checker is faulty, then your term papers, everything that comes out of the printer could have some mistakes. But let's say you didn't have cancer, you have a mutation. How likely is that gene to express itself as something called penetrance? Is that gene going to actually express itself or maybe not express itself? And we can even start to pinpoint on the gene the little pieces of the gene that make it likely to turn into cancer or
Wow.
not so likely to turn
Wow.
into cancer. But those tests, guess what? They've only been validated in Eastern Europeans. Right? That
Right.
SNP,
Here we
I'm talking
go.
about
Here
single
we go.
nucleotide polymorphic, SNPs, the SNPs, the little portions of the genes. They can give you a risk score and say, okay, you have a mutation, but your risk for cancer is this. You have a mutation, but your risk for cancer is lower. But we need to test our genes in order to be able to tell if those little segments are right for us and if those risk scores are accurate for us.
Yeah, but also it speaks to like triple negative. Like I don't have any mutations, but if my great aunt was 42, it could be pretty likely that she died of triple negative, right? Who knows? But also I think we don't know about the genes for triple negative. I think it's something that we haven't uncovered yet. And Dr. Maya, you could probably speak to, where are the research opportunities to think about how we should even be thinking about this research differently for a genetic profile. What should that look like? Does it include, is there are there things that we're missing for Black breast cancer?
Yeah, I mean, I know there are several research groups out there currently who are looking at exactly this. Like, how can we more granularly refine triple negative breast cancer to be able to deliver better care to predominantly Black women, since
Right,
Black women
right,
are much more
right.
likely to be affected. One of those folks is my mentor at Vanderbilt. Dr. Tua Powell is working on this exact question, funded by the NIH, about how do we understand how triple negative breast cancer from a genetic standpoint comes to be and a genomic standpoint comes to be in Black women. How can we better identify and refine what we know about triple negative breast cancer, so that with the hope that maybe one day there could be targeted therapies for this particular breast cancer. Because I mean, that is where you really run into issues, because unlike things like HER2 positive breast cancer, like there's no equivalent target for triple negative, and that's
Right.
why we see the outcomes and ultimately end up being so poor for so many women. And so when I see great research being done like that, I am definitely hopeful. The issue is that there's not enough of it. There is not enough funding. There's not enough people working towards these specific issues. I mean, it's happening in pockets for people who are deeply committed and care, but it's certainly not the effort. I quite honestly often wonder if triple negative breast cancer affected other groups of women like it does Black women. Would we see
Hello.
more research,
Right.
more funding, more effort
Right.
on these initiatives? And I don't know that I want the answer to that, quite honestly. And so
Yeah.
that's kind of my half and half view, that I am in some ways optimistic when I see the work that is going on with some of my colleagues, and in particular the sort of things that my mentor, who is a clinical geneticist, is working on. But at the same time, it could always be more. Because this is where folks are predominantly having the worst outcomes is with triple negative, because we just lack those targeted therapies so that they can live longer, like folks with ER positive breast cancer, like folks with HER2 positive breast cancer.
And not die like the two that died this weekend, right? But you know, also that some work is happening at Will Cornell with, you know, Melissa Davis, Lisa Newman, that they've identified a gene called the Duffy gene that is in Ghana. And it's connected to triple negative. So that's not even on the panel that we test for. So there's so much work that has to be done here to help us. Gosh, it's like, you know,
I wondered if men got breast cancer more, right, at an alarming rate, as we see the increase in male breast cancer. Like, is there a tipping point at which men are going to get really concerned, and all of a sudden the needle's going to start moving a lot faster? I'm very curious.
It would have to be white men, because look at even, you know, the ACS numbers just came out, and the prostate numbers for Black men suck. They're
Right, but the headline is that it's, you know, it's gone down overall.
Yeah, but it's not. But then, you know, that's not for the Black people, right? And the Black.
And Dr. Rowe, can you talk about the connection? We're talking about men between, is it prostate and or another cancer that's related to BRCA, I call it BRCA, sorry, BRCA. Are any cancers in men that might be your father, your uncle, your grandfather have that might impact you as a Black woman with breast cancer?
So yeah, you know, when we look at who meets criteria for genetic testing, one of the criteria was having a family history of very aggressive prostate cancer in the family, or young relatives, dad got diagnosed 50 or younger, pancreatic cancer, melanomas. You know, so there are in the syndrome, the hereditary breast and ovarian cancer syndrome, which is what BRCA represents, the 1 and 2 make up this hereditary breast and ovarian cancer syndrome. It's not just breast and ovarian, but there's pancreatic, prostate, and melanoma, and male breast cancer as well. And so when we hear lots of, or 3 or more relatives on one side of the family, and people need to make sure that they don't just think it's on mom's side or on dad's side, either side, but 3 or more, right, relatives that have any of those cancers in the syndrome: breast, ovarian, melanoma, prostate, rare cancers, pancreatic, rare cancers, ovarian. Any family member with that, male breast cancer, any family member in your whole lineage, your whole history with male breast cancer is a red flag, and you meet criteria for testing. But prostate is one of those BRCA-associated tumors, and we're starting to now test men with aggressive prostate cancer as well, because, you know, maybe their mothers didn't have breast cancer, maybe they never knew, and nobody shared with them what was going on with a woman's breast in the family, right? They're going to be in the dark about things like breast cancer. They don't know either, and so they meet criteria for that testing too.
Thank you for that. Yeah.
Wow. Yeah, I know there was a study a couple years ago too on colon. There's a study on colon connected to triple negative colon from the dad.
My dad happened to a good friend. She got diagnosed with triple negative breast cancer, and then her father was diagnosed with pancreatic cancer. And so that connection, if they had done the genetic testing, could have been, you know, something to look out for. So it can also work in the reverse. And then, so let's say I get my test done. What I'm thinking about generations, my siblings, my children, my grandchildren, and about testing with that. Any thoughts about that?
Well, isn't it that that the person with the cancer gets tested? So I was told that if I didn't have any genetic mutations, then my kids are okay. They don't need to be tested, right? So it's really the person with the cancer that needs to be tested. Is that correct, you guys? I mean, is that how it should work, or should?
So yes, but that's in relation to your children. You can't pass on what you didn't inherit. But your siblings, on the other hand, have a percentage of risk associated with, it's like I think a 25% chance that they could have a mutation that you didn't inherit. So
I wasn't told that at all. I was told that my sister is safe because I don't have one. So I'm calling her now and saying, you got to get genetic.
Yeah, and it's a little bit, as they call it, Mendelian, like the genetics of it, in terms of children and the rate of the risk of each child inheriting from a parent. But it's 50% children. So if you inherit a mutation, your kids have a 50% chance of inheriting it. But if your parents had a mutation, each child has I think it's a 25%. Each sibling has a 25% chance.
And
And
some
don't quote me on the genetics, but I do tell siblings that they're not necessarily out of the woods just because the sibling who had cancer tested negative. It's a very specific conversation that needs to happen with a genetic counselor. You need to take into account the entire family tree, but just because one person's negative, that means you didn't inherit it. It doesn't mean it doesn't run in your family.
What about my cousins?
They too, based on family history, should have a conversation with a genetic counselor and decide if testing is right for them. If they don't have much history on their side and you test negative, then there may not be much of a motivation to test, but it could still be helpful for them to know that they're negative for mutations,
Yeah.
right? Even
Yeah.
though we suspect they're negative, they can confirm that they're negative for the mutations that we know about. And Laura, to your point about colon cancer, we've been saying for years that Lynch syndrome, one of the colon cancer syndromes, might be associated with breast cancer. And we still haven't proven that clear-cut association. But, when patients get diagnosed with breast cancer within about a year of diagnosis, I'm talking to them about getting colonoscopies because it's really important to make sure that colon cancer isn't lingering and that there aren't abnormal polyps that could be precancerous, because when the cells start to make mistakes, they have a tendency to make more mistakes. And so we can catch those things early, but we haven't found the gene link yet, but we suspect that we may in the next, 5 to 10 years. There may be a very clear association with colon and breast.
Well, I had a colonoscopy. It's time for my next one, and I'm having it in a couple of months. So I guess it was 3 years ago, but I definitely had polyps. 3 polyps. So,
Same, same.
so I have to
But
be,
remove benign, but it's best to do
yeah,
it. I
yeah.
know it's not fun drinking the juice,
No, no, it's not fun drinking the juice, but you got to do it. You got to
but you
do
lose like 5 pounds instantly.
I know. The thing is though, there's a cancer that you can prevent.
Yes.
And so you have an opportunity to prevent that one. So take it, for God's sakes. We can't prevent breast cancer. But I mean, there's so many things. I think also just, I think we've uncovered a lot here, but at the end of the day, here we go. Black women, do what you got to do, girls.
Right.
Do what you got to do. Here we go again. We have to do this work for ourselves because, no one's going to ask you. And, we got to stand up and say, hold on, wait a minute, take your hand off the door. I'm not done yet. I need genetic testing. And that's what we got to teach everyone every day. So, we have a lot of work to do just in that area of being the CEO of our own health. Here we go again.
So Ricky, let me know when it's okay to also share some other updates on SOS and invite people to attend.
Yeah. Go for it.
Great.
Now's
So
the
thank you
time.
so much.
Absolutely.
So with SOS, we started SOS Soul Filling Our Sisters last year. It's around total well-being.
Soul filling our sisters.
That's right. It's total well-being, mental, physical, and spiritual health, because we know that stress is an immune suppressor, which allows bad things to happen in our cells, like cancer. And so it's 90 minutes. It's every 4th Saturday of the month. It's virtual, and we have experts in each of those disciplines. Our next one is January 28th, and we'll be focusing on fitness, food, and finding peace. And then we'll have an encore performance of Dr. Maya will be at our February event, which is around Black History Month, Black Genes Matter, and we'll be talking about my DNA, my destiny. Followed by March, we're going to be talking about sexual health after a breast cancer diagnosis with experts in that field on how to navigate that. So thank you so much for letting me talk about that, Ricky, and how we collaborate together.
Yeah, we'll put that in the comments, Laura, so people can find the link to join you,
Okay, sure.
and we'll put it in our e-blast. But, the more we talk about this, the better, you guys. And You know, I so appreciate all the work that you're doing, and Dr. Maya, you know, kind of, you know, bringing new knowledge to this. Because even when I did genetic testing when I was sick 11 years ago, but then I did it really about 3 years, right before COVID. You know, Dr. Regina said you should do it again. And because, you know, the gene panel has grown. And I remember the day she called me with the results, and she said, well, you don't have any mutations. And I said, well, that's good, right? She's like, hmm, I don't know. I don't know. We don't know enough to be dangerous, you know, so we want to do it. And for me, I'm done with treatment, thank you, God. But for someone who is in treatment or needs treatment, it is critical, because now it can dictate how you are treated. It can dictate what you do, whether it's surgical, whether it's chemo, whatever. And it's so important to have those insights.
Yeah, and I think it's important to ask and ask again, you
Yeah.
know, especially if you
Yes.
are diagnosed with recurrent disease, with metastatic disease, like the clock starts all over again. The slate is wiped clean, and all that testing must be repeated to look for new mutations that could have arisen,
Mhm.
that could have come up.
Mhm.
I don't know the word,
Yeah,
but
you got it.
it's important to make sure that your doctors are looking at all of those things and partnering with you and help you understand it to the best of their knowledge and the best of your knowledge. And ask those questions. Go to the websites. You know, if you have questions or you're not sure what to ask your doctor, you got some wonderful resources right here for how to have those conversations. And if you are interested in participating in a clinical trial like that of Dr. Maya's, how can folks get involved in or how can they see your research and maybe look
Yeah.
at some of your publications and follow your work?
Sure. So I really strive to make my work publicly available. And so I have a personal website that folks can tap into. But in terms of tangible resources for folks around getting genetic testing, as I mentioned, I'm not a clinician myself, but my mentor is a certified genetic counselor or a certified clinical geneticist, I'm sorry. And she has an open enrollment study for individuals who are interested, want to figure out if they are eligible for genetic testing. And if they are deemed eligible for genetic testing, they will be connected to resources to be able to facilitate that at low or no cost. And so
And that's
we
people
can.
who don't have breast cancer. That's anybody can do that, right?
That's both people. So
Okay.
people who meet the criteria that Dr. Mo was talking about regarding family history. So people who are at risk or people who currently have breast cancer or are breast cancer survivors. They don't necessarily have to be undergoing active treatment. We can put the link in the comments for folks to access, but it'll ask some questions about family history and things of that nature to determine if folks are eligible. We'll provide some education around genetic testing as well. And if folks are deemed eligible, as I mentioned, they will be connected to those resources to be tested at low or no cost.
That's great. Yeah, if you give me that info, I'll put it in the comments.
Absolutely.
Mo, you brought up something, you know, just now when we started talking about, as a survivor, how often should you get genetic testing, like after you've done with your treatment?
I think the recommendation, and there isn't a hard fast one, but probably about every 10 years or so.
Okay,
There may be some changes
okay,
in the panels. We may have more genes, but the companies themselves will continue to reclassify things like variants. So when you get that result and it says you have a variant of uncertain significance, it means we don't know enough information to know if this change on your gene is a change that could mean cancer, but they can quantify it and say it looks like it might be a low risk for cancer or could be higher risk for cancer. But the companies continue to do research to figure out if
Mhm.
those variants actually go on to become new hotspots that cause cancer. And so you can check back in with the company that you had testing with also. If you had Ambry or Invitae or Myriad or whatever company, and you can say, hey, I got tested 10 years ago. Are there some updates? Should I get what's called update testing? Should I get update testing? And they'll tell you whether or not you should get more testing, or if there's been more information that's come out since the last time you were tested that might make you eligible to be tested again.
right.
So we can always get an update. I remember I first got tested for BRCA1 and 2 in early 2000s because of family history, and I never had the full panel. And a few years ago, I had the full panel done. So they covered the update on 1 and 2 and all the other stuff. So, you can definitely ask for that. Insurance should cover it. There's resources available. Dr. Maya just told us about a trial that's even looking at that. So I would say for no one to count themselves out or think that it isn't relevant, even if you don't have children, right? Even if it doesn't seem to, if you're the only one in your family that has it, you could be the first person to have a
Have it.
mutation
Right.
in your
Well,
family.
yeah, you first
Yeah.
person. But even, my Dartmouth roommate, Jan, Michelle, she didn't get genetic testing when she was sick. And so, at her checkup last year, I guess she's 10 years out now. She was right behind me, 9 or 10 years out. And her doctor said, I don't see genetic testing in your file. And she's like, yeah, I never had it. And great insurance, whatever, didn't get it. And so she had it, and she has BRCA. And so she had gotten a lumpectomy. Actually, no, she had gotten a mastectomy, but she went and she had her ovaries taken out last year after finding that out
Right.
10 years later. But I mean, that was just, she got a new doctor. Her doctor had retired or whatever. And the doctor said, I don't see this in your profile.
Yeah. And
So-
knowledge is power. Even if she was never going to get an ovarian cancer, guess what? She has reduced her risk dramatically
Right.
from 50-60% in her lifetime up to age 80 to less than 2 to 4% or something. Like those, you should have the ability to make those decisions for yourself. We don't get to take that away from anybody.
Right. No, we shouldn't. Yeah. Wow, lots of stuff to learn, lots of stuff to talk about. We got to keep it up, Laura. Thank you for your work, Dr. Maya.
Yes, we do. I mean, there's a lot that we could do. I know it's a lot to take in. It's just so important, just like everything else, is to be your own CEO of your health, as
Yeah.
Ricky said.
Yeah, you got to be your own CEO, and we'll help you with the checklist, and we have lots of resources. Laura's got lots of resources on her site. We'll publish everything in the comments, and just stay informed, stay on top of it,
Beautiful.
Thank you, guys.
Yeah,
Thanks for
as
having me.
always. We hope it's been relatable and reliable and real. That's what we set out to do every Wednesday night on blackdoctor.org on the Doctors Inn. And we're so thankful to our sponsors, to our guests, to the researchers, to the advocates, to the breasties, to people watching and put questions in the chat. Keep them coming, because it's a new year and we want new questions. We want new ideas. We want all of your input on how to make this thing better for all of us. So we are just grateful is the word for this Wednesday. So thank you for joining us.
Thank you.
Breasty love.
Breasty
Doctor is
love. The
in.
doctor is in. Breasty love.